Yes, thank you. And I just follow up on the previous talks, and I'm going to speak a little bit more in detail on pro-hemostatic treatment, but again focus on the patient with major blood loss. And we do see many patients with major blood loss in the hospital, and it depends again a little bit on your setting, whether these are trauma patients or patients who are patients in a military situation, but also surgical patients very often have a lot of blood loss. Think of major cardiovascular procedures, liver transplantation, although that has been changed a little bit over recent years, but also major orthopedic procedures and so forth. And I'm not going to speak about transfusion or correction of coagulation because it has already been discussed, but I'll focus in this talk on pro-hemostatic agents. Hemostasis is extremely simple specialism within the medical specialisms. We only have two diseases, that's thrombosis and bleeding, and we can manipulate the coagulation system, and of course that's known to everybody. You can give anticoagulants, which are highly effective in the prevention and treatment of thrombosis, but they increase the risk of bleeding. But on the other hand, similarly, we have prohemostatics, and they can be effective in the treatment and management of patients with bleeding, but at least theoretically may increase the risk of thrombosis. You can apply pro-hemostatic drugs actually at three levels. You can improve primary hemostasis, you can now stimulate thrombin generation and fibrin formation directly, and of course we do have the antifibrinolytic agents. Well, let's start with primary hemostasis. And of course, giving platelets is very easy and very well-known intervention that may improve primary hemostasis. But there are also a lot of drawbacks associated with platelet transfusion, and I'm not going into detail here, but the formation of antiplatelet antibodies is a very frequently occurring complication of giving antiplatelet antibodies. Some studies show that in patients who never received platelet transfusion, a substantial number of them already after one combined 5 or 6 donor transfusion of platelets generate antibodies, which is not that bad in itself, but if they need repeated platelet transfusions, it may have result in a much lower yield of this transfusion. Infectious complications may occur with platelets, which are a little bit difficult to sterilize, and although it's not very common, it may occur, and sometimes donor-depending and logistics is an issue in transfusion of platelets. So we are looking for alternatives. Well, this is not an alternative, but in some situations it's helpful. It's desmopressin or diamine or D-arginine vasopressin. It's actually a modified physiologically occurring vasopressin molecule, which is one of the smallest proteins in our blood. And actually it has been de-ammonized, and it has D-arginine instead of L-arginine, and that makes it a molecule that has retained its antidiuretic properties, has lost most of its vasoactive properties, but has a profound effect on release of von Willebrand factor multimeres, and thereby is a pro-hemostatic agent. And indeed, it shows shortening of the bleeding time, and in some patients it may be beneficial, although the effect may be moderate to mild in patients with excessive blood loss due to antiplatelet agents or other situations that may affect platelet function. Well, ideally we would have artificial platelets, and there is lots of research going on with artificial platelets or artificial compounds that may mimic platelet function. And this is just an example of one of the products that we have been actively involved with, and that is now in phase 1, phase 2 clinical studies, although they show so far mixed results. But the whole idea is that if you introduce microcapsules coated with procoagulant proteins or receptors or ligands, it may be effective, and this particular compound was highly effective in animal models, but there are many more of these products actually now under review, under consideration in preclinical studies, and some of them in phase 1 or 2 clinical trials. Well, what about the other end of the spectrum, the antifibrinolytic agents? We actually have two types of antifibrinolytic agents. This is a simplified scheme of the fibrinolytic system. You probably know it. The key enzyme here is plasmin that can degrade fibrin into fibrin degradation products. And plasmin occurs when plasminogen is activated by endogenous plasminogen activators. And you can block this system at two levels. In the first place, a protein can block directly plasmin when it's been formed. And then we have lysine analogues like tranexamic acid or epsilon aminocaproic acid that can block the conversion of plasminogen into plasmin. And these antifibrinolytic agents have been extensively tested in a myriad of clinical situations, most notably in cardiac surgery. And this is just showing you in a nutshell the effects, and they are impressive in patients treated with aprotinine versus placebo, at least in a meta-analysis of the studies. There is an effect on blood loss, on rethoracotomy, even on mortality. But also for the lysine analogues, this seems to be true, although since these are much smaller studies, this is not statistically significant for mortality. But aprotinine has become a little bit less popular because apart from its beneficial effects, it's become clear that there are also many adverse effects and safety issues. And this was actually started with a publication a couple of years ago in the New England Journal of Medicine by Dennis Mangano. And this was actually not a prospective study, but this was a retrospective trial in not even a large number of patients, although 4,000, of course, is still respectable. But they did a retrospective analysis comparing different interventions and adjusting or correcting the analysis on a propensity-based method. And what they were able to show is that on the renal outcomes, the need for renal dialysis, the worsening of renal function, or a renal composite endpoint, aprotinine had much more risks than tranexamic acid, epsilon aminocaproic acid, or patients that did not receive an antifibrinolytic agent. And on many other outcomes, although not statistically significant or only a little bit statistically significant, there were similar negative effects of aprotinine. And that sparked the interest in the lysine analogues that have a very different point of impact. How do lysine analogues work? It's very easy, actually. If you need to convert plasminogen into plasmin, you will need binding of plasminogen activator and plasminogen to fibrin. If there is no fibrin binding of this complex, actually the conversion of plasminogen into plasmin is a very slow process from a biochemical point of view. And this binding of these molecules to fibrin occurs through the lysine binding site. There are lysines on fibrin, and they bind to the lysine binding site on plasminogen. And actually, the lysine analogues competitively block these lysine binding sites. So plasminogen cannot bind to fibrin anymore, and the conversion of plasminogen to plasmin occurs much more slowly. Well, then, of course, we were interested in whether aprotinine or lysine analogues would compare directly, again, in high-risk cardiac surgery. And although it seems that there is only a small difference here, with very large numbers, it was clear that aprotinine had a less favorable outcome. This is the percentage surviving at 30 days in terms of mortality directly compared with tranexamic acid and aminocaproic acid in this trial. And that was actually the end of aprotinine, and most centers now moved for high-risk patients to lysine analogues like tranexamic acid. But then the interest in tranexamic acid was further sparked, and there was also another trial in patients with severe trauma that, of course, can also present with major blood loss. And this is a very elegant trial, at least in my view, a worldwide trial in a large number of hospitals in many countries, not only Western world countries, but also developing countries, more than 20,000 patients, one of the largest trials in the literature, and a very simple design, just looking at very simple outcomes and survival. Tranexamic acid was given within 8 hours of injury as a loading dose, 1 gram over 10 minutes, and then another gram over 8 hours. Not very complex. And as already mentioned by Dr. Gaudier, it's a very cheap treatment also that can be applied everywhere in the world. And here you see the results of the trial. And impressively, there was a decrease in any cause of death of 1.5%. And you may say, well, it's only 1.5%, but this, with a very high number of patients dying of bleeding after trauma worldwide, I'm going to show you a figure in a second, is still an interesting and very significant result. On the other hand, one can say that still 14.5% of patients, even in the tranexamic acid group, had died after trauma. So there's a lot of things to gain in this population, but still a 1.5 reduction with the simple intervention is okay. And this indeed was related to less severe bleeding in the tranexamic acid group compared to the placebo group, which was also clear that all these deaths occurred in the very early stages. And a later trial showed that indeed that for tranexamic acid to be active in these patients in this setting of excessive blood loss, it needs to be given at a very early stage. And at a later stage, it may even be more detrimental than it may be supportive in these patients. That's actually shown in this subgroup analysis. This was done later on. Time from injury, less than 1 hour, 1 to 3 hours, more than 3 hours. And as you can see, if it's been given within 3 hours after injury, it's highly effective, whereas it's not when it's given later on. Also, of course, people were interested in the incidence of thrombotic complications because patients with trauma do have a higher risk of thrombosis and embolic complications. And there were actually, as shown in this table, no differences between tranexamic acid and placebo. The only adverse event, that's still a matter of debate whether it's a true effect or not, is a slightly higher incidence of epileptic insults in the tranexamic acid group compared to the placebo group. So this is an interesting result, and I think it changed most of the trauma protocols in the world. And rightfully so, because this is, on a yearly basis, the number of patients who die because of trauma. And in many parts of the world, this is one of the most important causes of death in a large group of patients. And it's been calculated that if every severe trauma patient would have received tranexamic acid, one can prevent more than 70,000 deaths worldwide on a yearly basis, which is impressive, I think. Well, let's speak also a little bit about stimulation of thrombin generation and fibrin formation. And the interesting drug there is, of course, recombinant factor 7A. Recombinant factor 7A has been licensed for the treatment of patients with hemophilia, so patients with factor 8 or 9 deficiency who have developed an antibody against their factor 8 or factor 9. So it's very hard to treat them with the conventional factor concentrates. And in these patients, it's been shown that recombinant factor 7A is a very effective coagulant agent. It has also been licensed for defects of primary hemostasis, at least in Europe, and for a small part in the United States and other parts of the world. But that's actually not the major use of 7A worldwide. There's extensive off-label use. For example, in patients who present with excessive blood loss. Recombinant 7A indeed generates thrombin, without any doubt. But there is quite some debate whether it's only locally at the site of injury, where there is tissue factor, or whether there is also systemic thrombin generation. And in that case, it may be that the risk of thrombosis is increased. Well, why is recombinant factor 7A so popular? Well, most of this is based on anecdotal evidence. And this is just one of these anecdotes. This is a patient who had undergone a major surgical procedure and was profusely bleeding. Each of these black dots here is red blood cell concentrates. All these dotted dots here are plasmas. And this is 6 donor platelet concentrate here. And that at a certain point in time, these authors decide to give a single injection of recombinant factor 7A, which has an immediate effect. And it stopped bleeding in this patient, and it stopped also the requirement for transfusion. Well, this is, of course, a case report. There is no control group. There is no, it could have been chance. If this would not have worked, the authors would have probably not published this, and so forth. And the difficulty is that most of the literature on recombinant factor 7A is anecdotal evidence. But on the other hand, if you can do an intervention like this in an intensive care patient who is profusely bleeding and nothing helps in these patients, you can make the patient and his family and the nurses and everybody extremely happy by coming in with just one injection and stop the problem. And you make yourself tremendously unpopular with the hospital administration because it's extremely expensive. Well, there is some trial evidence in 7A that does support its use, but also that leads to the conclusion that it should not be used in some type of patients. This is one of the first trials, and this is a proof of concept trial in a perioperative setting in which there was a lot of blood loss. You see almost 60% of patients were transfused in the placebo group, and this was reduced to no transfusion with a relatively low dose of recombinant factor 7A. But much more interesting, of course, is a large trial in patients with trauma, and there have been a couple of studies in patients with trauma, but this is, I think, the most important, in which there was a direct comparison of 7A and placebo, and interestingly, both in blunt, or specifically in blunt and less so in penetrating trauma, there was a positive effect on massive transfusion of 7A compared to placebo. But unfortunately, translated to survival rates, there was actually not a significant difference between 7A and placebo. So most of the trial protocols advocate not to use 7A in the early phase after trial. And this was done before the tranexamic acid studies were published. So these have not been taken into account in this study. But 7A actually have lost his place in most of the trauma protocols that I've seen so far. And it's also not completely free of adverse events. Because I already told you, if you have a strong enough pro-hemostatic, the risk of thrombosis, at least theoretically, may be there. And that may also be the case in 7A. There were first some anecdotes, some reports of thromboembolic complications after the use of recombinant factor 7A. But actually, if you look systematically in all randomized clinical trials, published and unpublished, that have been done with 7A, you come up with the number of more than 4,000 subjects that have been subjected to this administration of the drug. And then you'll find there is a slight increase, 1.7-fold increased risk of having arterial events after the administration of 7A compared to placebo. And this particularly seems to be coronary events. There the risk, the odds ratio is 2.4. And especially in the elderly population that have received very high concentrations of recombinant factor 7A. So I'm not saying that you should never use 7A, but you should realize that if you use it, you also expose your patients to a slightly increased risk of thromboembolic complications, which needs to be offset to the potential benefit that you aim to achieve in that given patient. And that brings me to my conclusion. I think that management of severe bleeding requires a multidisciplinary approach, but amongst all the factors that are important here, pro-hemostatic treatment may have a contribution to the outcome in patients who present with excessive perioperative or otherwise blood loss. Data on efficacy and safety of the various interventions, pro-hemostatic interventions in severe bleeding, are there, but I think need to be expanded. I think we need a little bit more information for each and every specific clinical setting before we can firmly advocate that it should be used or should not be used in these settings. And for individual patients in the meantime, they may provide a potential, a life-saving potential, especially when all other treatment options have failed. Thank you for your attention.